All right, Chapter 8 talks about atraumatic care of children and families. Now, there's a lot of information in here that's going to be a repeat of information that you've already seen or will see in Module 1, but it does have some great boxes in the chapter as far as teaching at each developmental level. So I kind of included this chapter, even though it does have some redundant information in it. So atraumatic care, family-centered care, big topic in kids. We try not to poke and prod on our children. Not a lot of procedures in this particular setting, the pediatric setting. We, even as nurses, try not to, we try to stay least invasive. We try not to do anything traumatic. We keep the traumatic incidences at a low, or we try to. Sometimes there's things you just can avoid. Sometimes you just have to start an IV, or you have to change a dressing, or you have to IND an abscess. So sometimes it's unavoidable. But we try to prevent and minimize that those traumatic processes. Also, family-centered care, big, huge issue. Always involve the family. They are the ones that are going to be taking care of these kids when they go home. So family-centered care, big topic. All right, some techniques for providing atraumatic care. Of course, you're going to go back to the good old therapeutic communication. Therapeutic play sometimes helps with the traumatic events that might take place in the hospital. Child education and parental education, both very important. And I know we have some child life specialists out there in our class this time. They are wonderful in this area. We are very fortunate to have great child life specialists at Cook Children's and at Dallas Children's. They have a wonderful child life specialist program. I'm sure any other pediatric facility, Texas Children's down there, San Antonio Children's, they all, I'm sure, employ child life specialists. And Med-City Dallas, I don't want to leave you out. Child life specialists, so what is their role? They are supporters of the nursing profession and the paramedics in the facilities. They keep kids busy. They keep them developmentally on pace if they're in the hospital. They provide support for the siblings. They provide support for the parents. They engage the patients with therapeutic play. They use distraction techniques to help us during procedures. If there's a death, they deal with siblings, etc. So they are very invaluable. Some things to prevent, minimize physical stressors in the hospital. Make sure you get the child involved. Positioning is important. Distraction is key. Telling you, bubbles are magic. You'll hear me say that probably every podcast. Bubbles are magic. Some things to distract if you're going to do a traumatic procedure or a painful procedure. We talked about this, or you will hear about this in the pain management podcast, but blowing bubbles, music, things on the ceiling. You'll see in the patient rooms and in the treatment rooms, there's things on the ceiling for them to focus on. So those are all good distractors. Family-centered care. Okay, so you have to assess the family and the family dynamics upon admission, really, of your kids in the hospital, and it has to be an ongoing assessment to see how they're coping. First of all, to see how they cope, and then how they are coping with the hospitalization, the stressors related to that. Always respect the family and their opinion. Even though you might not agree with it, you have to respect it. Family may be extended family. It may be grandparents. Grandparents may be caregivers. It may be great-grandparents that are caregivers. So make sure that you assess that as well. Who's who in this ballgame? Always address the cultural, the racial, the ethnic, socioeconomic diversity. Make sure that you pick out their strengths. Don't just focus on their weaknesses. are there areas of opportunity, as I like to call them? Make sure that you say, oh, you have lots of support in this area, and that kind of gives you get you in their good graces. So make sure that you identify those strengths and use those strengths. Be honest. Don't sugarcoat things. Be honest, but be empathetic in the same breath. And what happens when you do this? Well, kids' anxiety is decreased, parents' anxiety is decreased, your anxiety is decreased, so everything just goes a lot smoother for everybody. You can tell how old these pictures are. That is definitely an old bed there. Encourage your parents to sleep in or to room in with their patient, with their kids. In every hospital room, there's always a place for the parent to stay. So encourage that. Good, effective communication and teaching. Another focus of this chapter is communication with kids and with patients and with their parents. So good communication is very important. Open communication is very important. Conflict resolution is very important. So you'll learn how to deal with some parents that might not be so nice, but you still have to provide them with respect, and you have to take care of their kids in an appropriate manner, and you have to address their concerns. So it is a different world than adults, because you have actually two patients. You have the family and you have your patient. All right, sometimes there is a language barrier, but again, you still have to maintain that communication. So interpreters, we do use a lot of interpreters. We call them patient advocates. Some places use the blue phones, the language lines, as interpreters. Some places have the computer web-based interpreting system. Those are all good. One thing you never want to do is use the kids as interpreters. Okay, housekeeping, not appropriate interpreter. So make sure that you have a medical interpreter. Most physicians are pretty good at speaking at least Spanish. Some of them speak some other languages as well. But it's definitely necessary, and we're legally responsible to provide them communication in their own language. That includes sign language as well for our deaf parents. Okay, don't use kids, avoid side conversations. These are some good tips when you're working with a translator or an interpreter. All right, family education. So teaching is a huge component of pediatric nursing. Lots of different things that you need to take into consideration when you're doing family education and child education. Developmental levels, and that's not just the children, okay? The family literacy, you need to take that into consideration. You need to do a good literacy assessment to see how much they really, can understand the information that you're giving them. Physicians, encourage your physicians to talk with the parents. They're the information givers. You are going to be the educators, but they give the important stuff like test results and things like that. If there's a language barrier there, please stand up for your patient and get an interpreter so that you make sure that they understand exactly what the physician is telling them. If there's a surgical consent involved, absolutely have an interpreter there so they understand. All right, some specific learning principles related to the kids. Again, that relationship, key to good communication with kids and good education with kids. Age and developmental level, always. Adolescents, they can either be very receptive to your teaching or very deflective of your teaching. So again, making that connection, that relationship is going to get you far with adolescents. When you're dealing with parents, remember adults are, for the most part, self-directed. They pull on a lot of their past experiences and their other friends' experiences. Well, my friend's son, or my nephew, they used a lot of those past experiences. And when I was a kid, they used those experiences as well. All right, when you are assessing learning needs, make sure you assess the child and the family for their any barriers or anything like that. Good old nursing process. Make sure you document. Document your education that you give the families. Document your education that you give the patient. Very important. Some questions to ask when you're doing your assessment regarding culture. Who takes care of the kids at home? Who's the boss? Who's the authority figure? Now, you're not going to come right out and ask those questions, a lot of them, but as part of your assessment of the family dynamics, you need to make note of that. Who answers the questions when I ask? Does mom look at dad? Does dad look at mom? It may be either. So there are some things on here that you can ask directly the questions, any special dietary needs, any special clothes or adaptive equipment needed. So just choose your words. Some things that might alert you to some poor literacy skills if they, when they sign their name. You can kind of watch them sign their name. If it takes them a long time to sign their name and spelling, etc., they may have some learning needs. Non-compliance. I forgot my glasses. I'll read these at home. No questions when you're giving discharge instructions. That's a red flag. If they don't have any questions, you want to make sure that they understand everything. So always ask, do you have any questions? Or what questions do you have? Now I love this. This kind of tells us how parents learn, patients learn, okay? So after 2 weeks, I think it's very interesting, we only remember about 10% of what we read. That's kind of worrisome to me, because if you only read the chapters on the HESI test, you're only going to remember 10%. That's a problem. So parents are the same way. If you give them a handout to read at home, in 2 weeks, they're only going to remember about 10% of that if they understood it the first time. 20% of what we hear, so seeing, hearing, a little bit better outcome, 30%. 50% of what we see and hear, 70% of what we say. So you can get parents to repeat discharge instructions back to you. You can get parents to repeat teaching interventions back to you. Okay, so tell me, how are you going to check your child's blood sugar? And even better, if they do it. So a repeat performance of the task that you've taught. 90% of that will be remembered in 2 weeks. So hands-on is best. Repeating information back. One of the things I always chart in my discharge instructions is verbalized understanding. And that means to me that they repeated it back to me. So some techniques to improve learning. Again, we just talked about all these. Use visuals. Hands-on approach is always best. How do you evaluate if they did learn it? Well, they can show you exactly how to do it once you've demonstrated a skill to them. Bulb suctioning is another one. We do a lot of bulb suctioning and teaching bulb suctioning. So you do it the first time, and then you have mom do it the second time. Okay? Document, document, document. If it wasn't documented, it wasn't done. So make sure that you document all of your teaching, your med teaching. As part of your discharge instructions, make sure that you document that you gave them the prescriptions, that you gave them medication information. All right, so let's go over to our chapter. Sorry, I didn't go back up to the top. One moment. All right. Oh, this is not the beginning either. All right. So atraumatic care, principles of atraumatic care. It would help you to kind of know these. I know they are kind of global, but do read through the box 8.1 there. All right, here's some information about child life specialists, and we did talk about them. Um, these are some things that they can kind of assist with. There's a few more listed here than on the PowerPoint. We love our child life specialist. All right, so this chapter, one of the things I like about this chapter, all of the tables have very important information. So if you read nothing else in this chapter, I can't believe I'm saying this, read through these tables, okay, and the care plan at the end. So here's some suggestions for atraumatic care, for nursing care. And again, we've talked about a lot of these previously, but some of them are new. Like if you know you're going to draw blood and you know that there is a possibility that you might get some medication and it could be IV, put a saline lock in, poke the child, do the procedure one time, okay? If you can prevent a future stick, then do it. Ask your physician, is it okay if we put a lock in? Or, if it's okay, do you want an IV or just lab? So think about that. Be an advocate for your patient. Here's some more distraction methods. Okay. Let's see. Oh, this one we talked about a treatment room. If there's a treatment room and you have an invasive procedure to do, utilize that treatment room. Make the child's hospital room a safe place. All right, so here, I love this table too. And we don't even think about it sometimes. If we say to a 4-year-old, we're going to deaden this area, or we're going to put some dye in there, they take those terms very literally. So choose your words. Be careful. Put to sleep. Put to sleep is kind of a, because we say if they're going to be sedated, we're going to put you to sleep, or if they're going to go to surgery, we're going to put you to sleep. Well, their puppy might have been put to sleep, and puppy didn't come home. So make sure you choose your words appropriately. All right, these two paragraphs, I said everything was in a box, but these two paragraphs right here with these little bullet points, really important. Okay, and they were on a PowerPoint slide. All right, communication, verbal communication, nonverbal communication. Make sure that you are approachable. If it's appropriate, sit down and talk to your family. Sit down and talk to your patient. That kind of gives them an at ease, and they'll open up a little bit more with you if you display that nonverbal communication. Here's our developmental techniques when communicating with children. These are all important. Breaks them down by levels. Somewhere it does. These are just some basics across the board. Introduce yourself. Make sure that they know who you are and they know what you're there for. Okay, here we go. Infants, toddlers, preschool, school age, adolescents. Important to know this information. All right, here's some more tips on working with an interpreter. Make sure you document also that you used an interpreter. A lot of the services that we use, like the Blue Phones and the web-based interpretation service, they'll give you an ID number. That way, if you have any questions, I'm sure that they keep transcripts of their interactions. So if you have any concerns later, or if legal needs the information, you have the number of the interpreter that you used. All right, goals of family education, important to know. We talked about patient teaching, learning needs assessment, we talked about that. Remember, everything needs to be about a 5th grade level if you're going to hand out education information. There's the red flags we talked about. 6 techniques to improve learning. Again, important stuff. Use a hands-on approach. See one, do one, teach one. Have you ever heard that? That is appropriate to use. Some teaching tips with young kids, and some verbiage to use, which is very helpful. Instead of saying this will burn, say this will feel warm. Not a lie. Don't lie to your patients. Tell them the truth, but use appropriate language and language that's not going to scare them. School-age children, adolescents, great teaching tips. Again, here's one of those misconceptions, the goals of teaching. This is a good answer that may or may not be gotten correct, so make sure you read through that. Documentation. Make sure you document. And there's our key concepts for this chapter. So, takeaway from this chapter, make sure you include the parents. Teaching the patients, teaching the parents, all a very big component of pediatric nursing. Okay, take into account the developmental level of the patient and the where are we of the family. Okay, so family dynamics, a good assessment of family dynamics is key. Sometimes you do that verbally, sometimes you do that just by observing their interactions. Y'all have a good day.